Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 113th episode of the Codecast podcast today. My name is Terry Fletcher. As all of you are probably working on month-end, year-end, and reflecting on 2019, and hopefully have started to make your business wish lists on what you can do better in 2020, I wanted to talk to you today about revenue cycle management transparency and how to make sure you have your eyes wide open for 2020 so you can make informed decisions based on data that you have, not based on assumptions that you are maybe thinking on how things are working. And I came up with this topic based on some consults I've been doing in practices lately in my area. And it's interesting how sometimes the management looks at things and thinks things are working in a certain direction. And then when you dive in and start asking questions and querying staff and all of that, you're just like, well, that's not exactly what's happening. So I wanted to really look at that today because there's been some issues with that we want to make sure that we're not repeating some problems, especially as it relates to our collections, our revenue cycle, and just how you're looking at your accounts receivable, because you're now at year end. And when we get to year end, month end, and looking at the new year, you know that your physicians are going to be coming to you if you are in the billing office as a manager, if you're a practice manager, if you're an administrator, and even if you're a coder, and they're going to be coming to you and saying, where's our money? What's going on? What's happening? And you have to have some transparency there. So the point of today's topic is to really look into that and to understand why it's important to have some of that transparency. When I use the word transparency, I mean for the practice to understand, and you as coders, you as billers, you as managers, to understand what's going on within your revenue cycle. So let's look at it from a clinical perspective. So for example, when it comes to a clinical performance, insights are essential, as you know. So for example, if you know that 50% of your patients are readmitted to the emergency room within 3 days of discharge, and the average readmission rate is, let's say, 20%, can you conclude that your clinical practices are flawed? Well, no, you don't have enough information, so probably not. It's only when you have the insights into why that's driving that particular metric, so something you can't control, such as growth in patients with diabetes or something like that, then you can begin to draw conclusions and make changes. So think of it this way. A scale can tell you your body weight, correct? But that's only part of the story. The scale doesn't tell us precisely why your weight is going up or down, or give you insight into the set of actions that triggered the weight gain. It's the same way when looking at your practice's bank statements and accounting reports. They only tell you part of the story. Your traditional financial reports alone, really are no longer able to provide the deeper insights that are necessary to understand how your financial performance and your metrics of a practice are actually working. Sometimes it just comes down to what you can't see rather than what you can see. It's the exceptions that are not typically brought forward by those traditional reports that you're running. And so good or bad, you can't always see it. And that's why when I've been going to some practices, they're like, well, we ran a report and found this. I said, but what is it that you're not seeing? And when I dive in further into some of the operating procedures, some of the workflows, I've noticed that this is where some of the flaws are. So it's important to know how well your practice performs, not just compared to last year, so in 2019, I'm going to say, but more importantly, compared to what you expected based on current conditions. The more data transparency you have, the better you can diagnose why it is you're on or off target. So let's look at that. So to understand how data transparency can drive decision-making, first of all, you need to consider an example of how knowing your performance in a particular area against benchmarked averages could indicate a larger problem that requires attention. Now, I don't want to get into a bunch of data mining and all that because I think it gets very confusing, but I'm going to give you just a couple. I have just 5 things I want you to think about. Here's my lists again. For those of you who know me, I love to make lists, but here's some essential metrics. And these are things that you can do very easily, even if you don't have the skill set of an MBA. I'm not looking for that. I'm just looking for somebody that can look at some information, can ask questions, and hopefully realize that there could be a hole in some of the practice numbers. Okay, and what those numbers could mean. So the first one, look at your percentage of AR over 60 days old, insurance versus patient claims. So when we look at this as a whole, when we're looking at the insurance versus patient claims, then what we're looking at here would be percentage of AR over 60 days old. Now, let's say we have a significant number of claims over 60 days old. Okay, that could signify larger problems such as charge lag issues, a change in the insurance collector's performance, or maybe they've been out for whatever reason, an increase in rejections from the claim scrubber. That's that third party, sometimes the clearinghouse, or what kicks it back if it doesn't go with this modifier, etc., or an increase in balances due from the patient. Remember what month you're in. It could be deductibles or copays or somewhere along there. So you have to take into consideration the report itself of just having an old AR doesn't tell the whole picture. You need to look into it further and figure out what's happening with collections on the back end. Number 2 is the payer-patient mix. Sometimes this can shift, and this is something that has been pretty, enlightening as I've been really kind of doing some due diligence on this. So a dip in cash is not always, and this is your cash flow, it's not always due to your insurance collector's performance. I think a lot of times the physicians who count on us to give them an understanding of our AR and our collections, sometimes they think it's all about a certain payer that's not paying. But you could have experienced a major shift in your patient population or in the insurance that those patients carry. So if you're seeing a higher volume of patients with lower paying insurance or high deductible insurance plans, you may see an increase in patients, but cash could be lagging behind historical levels as a result of the insurance changing. I had one practice that didn't even realize it, but because they picked up so much more hospital services, all of a sudden they went from being 20% Medicaid to 40% Medicaid. Well, talk about lowering your expectations and your reimbursement at some point. That's a complete shift in payer mix when they used to be 40% Medicare and now they're 28% Medicare. That makes a huge difference in what you're collecting. Another one, this is number 3, clean claims, first pass denials, and open denials. So if your clean claims or first pass resolution rate is bad, you may have underlying setup issues in the practice management system. A front office could be the problem with verifying eligibility or coordination of benefits, or a group of denials that are not being overturned by the insurance collectors. And I want to talk about that first pass, that clean claim. So I have a practice, another one, and if you hear about your practice on my podcast, just so you know, I have cleared it with you to put it out there, and I'm not saying who you are, and hopefully we're fixing that problem as we're talking through it. But I know a lot of you do listen to me, and I just want to make sure you know I put it out there so that this helps other practices. This is a way of behind the scene networking so that they can learn from not just maybe the mistakes you're making, but also you can hear it live and think, wow, yeah, that is actually something we're doing and we need to clean up as soon as possible, mainly because then Terry will come back in your office and be mad. But I just want to make sure that you're understanding where I'm coming from for that. But I have a practice that, and actually a couple practices, that their process is basically the doctor closes out the record, and then the record is supposed to go right to the, it closes out, and then it's authenticated. And then that night when somebody flips the switch, basically to send all the electronic claims, then it's supposed to already go. Well, what I found out after querying a bunch of people in the billing office and in the front office of many of the practices that have their own practice manager in each practice, this is a multi-specialty clinic, they basically said, yeah, the doctor signs off on it, but sometimes the medical assistant doesn't get to his or her work, and so then they don't close out the record for billing until the next day or the day after. Now my head spun around. And they said, and when there was an order, let's say this patient needs labs before they schedule their next appointment and so on, or something they need, the medical assistant would basically do what they have to do, or let's say an x-ray was taken that day, and it would get dated the date that they actually put it in, because your computer doesn't backdate. And so what happened is it would get closed out and the office visit was billed on one date, and then the lab work or whatever they did that day was billed on a different date because of the medical assistant not closing out the claim. Then it was caught, luckily, most of the time anyway, by the billing office, and then the claim had to be corrected before it got sent out again by the user, because they couldn't go back in and change it in the billing office. They had to go back to the medical assistant to fix his or her problem, and talk about a mess. Now you see how long that claim has lagged, and some of those didn't get caught, so they weren't clean claims. So just a mess on that end, and we have to make sure we're better than that. We want clean claims, first pass claims. And if you're getting a denial, you need to understand where that's coming from. It could be just a transposed number from some of the new claim numbers and some of the new ID numbers patients have. Number 4 is patient no-shows. So these are patients that have been scheduled for an appointment and obviously just no-showed their appointment. And if you think no-shows don't follow into the revenue cycle, you'd be mistaken. If no-shows are high, it may indicate communication problems with your patients. It could be a shift in patient mix, or it could be that you just need a policy for no-shows and a fee that's installed in patients. Remember, they have to respect your time as much as you need to respect theirs. You may want to consider also strategic scheduling, maybe switching to an online scheduler or implementing text or voice-based appointment reminders. I know, for example, I was scheduled to have an MRI on my shoulder last night, and I got 2 texts during the week about that happening. And so don't even get me started on what a nightmare that was. But anyway, the scheduler did remind me to show up. It would have just been nice if I had somebody other than a 14-year-old to do my MRI. Anyway, I'll get off that bandwagon for another time. But there's something there when it comes to no-shows that you have to figure out, is that time being filled by something that generates revenue? And that's where it becomes a revenue cycle problem, because now it just leaves the doctor with a gap, and we don't want to do that unless you have physicians that are actually utilizing that time to catch up on their documentation. And then the last one is non-contractual adjustments. So what is being written off of the accounts receivable, and was it appropriate? I would say there's a good percentage that probably isn't. Not all adjustments are insurance contractual, and many times they could be bad debt. They could be, I would say, inappropriate courtesy or professional write-offs. I always check on those. But in some cases, balances are being written off that either could have been preventable or are the result of untimely follow-up by the staff, or you're getting into a timely filing by the physicians not having their charts done. And so depending on the setup and the controls in your practice management system, these write-offs could be done inappropriately or allocated to legitimate write-off codes and hidden from sight. You may not see it, and talk about a need for greater transparency. This could end up losing the practice thousands or even millions of dollars annually without even knowing it. Balances where 100% of the gross charge is written off should be looked at very closely. And I'd want to see that, because then you'd want to say, well, are you just billing it when it's a completely bundled service? Or are you billing it with no expectation to get paid, which would be a false claim? But since the data is objective, it can confirm hunches for you. So it's one thing to feel like you're always chasing payments, but it's another thing to confirm that 50% of your patients scheduled on any given day have unpaid patient balances due to the practice fault or something that's not in your revenue cycle management. So the more you know, the greater ability you have to implement change. And saying that, similarly, data can also be surprising. For example, when you look at your non-contractual adjustments, you might see significant write-offs in a particular month for timely filing. So this could be more to possibly a systemic issue that you need to address with the billing office, or something you need to address with a particular physician. And if you're in a big group, and I try to reiterate to those physicians all the time, remember, one physician can be a bad apple that affects the entire group. It doesn't just affect that physician. If that physician is part of one tax ID, it's going to affect everybody. And if there's something that gets audited, or you're an outlier, or you can trigger for an audit, that's a problem. And you need to make sure that you have something in place so that that doctor is understanding of what the expectation is for compliance for them. And the biggest thing is, if they don't adhere, there has to be a penalty. There has to be consequences. You know, too many practices that I go to say, well, we have it in the physician agreement that they have to attend quarterly education on coding and documentation, and that they have to hit this benchmark of passing with 85%. And I said, what happens if they don't? And they go, well, they have to. Okay, again, what happens if they don't? Well, if nothing happens, why would they have the incentive to make sure they do that? And then here's some steps just to make sure how you get this monitoring of your practice. So the ability to monitor your practice's health through the use of this data. Once you're armed with the best, most up-to-date information, that's when you can finally make those decisions and asking those questions. And that's when you get into analyzing the information. We call those analytics. Then you look at the metrics data, and it can show you how you can identify those problems. So let's go back to the example of the scale and basically weighing yourself. So when you know your body weight is only part of the story, a scale were powered, let's say if it was powered by AI, so artificial intelligence, and can track calorie intake, metabolism, eating and exercise patterns, you'd be able to discern a complete correlation between dietary changes and a 10% weight gain from 1 month to the next. So let's put our billing and payments through the same and smarter RCM tools. So try to look at, instead of just making hunches or assumptions about things and embark on positive changes, try to look again, starting with maybe your days in AR over 60. Pinpoint where what this is from. And find out if the AR is due from the patient population that has increased, or is it patient balances. You can seek out best practices for improving collections either at the time of service or through proactive follow-up. And then you may decide to retrain the front desk staff to use a surgery estimator tool before a surgical appointment, if you're a surgery practice, to attempt to collect all unpaid balances before the patient sees a doctor again. I'll go back to my example last night of going to my appointment for my MRI. Basically, they said, okay, you have a $50 copay and you still have $27.91, so $27.91 on your deductible. So they said, bring in a check for that total amount. And I did. And that's what practices need to do. So sometimes when the practices are saying, we need to figure out where all the lost revenue is, transparency is the key to make better decisions, not making assumptions when you don't really know what's going on. So running the practice without data is like delivering medical care in the dark. It's risky and it can be dangerous as well. And without that transparency into the practice's financial performance, you are going to have a really hard time keeping operations afloat. So we want to make sure that you're really focusing on not only quality care to your patients, but being able to deliver that when we're talking about the revenue cycle management area. So my coding question today has to do with ICD-10 for 2020. So my Florida subscriber asked, did ICD-10 2020 add any new codes for atrial fibrillation? If so, what are they? So the answer is yes. For ICD-10 2020, which actually became effective on October 1st, 2019, we got 4 new codes for atrial fibrillation. So for long-standing persistent AFib, you would report I48.11, and then you also gained a code I48.19 for other persistent AFib. This includes not otherwise specified chronic persistent AFib as well, and persistent atrial fib. You also have I48.21, which is permanent atrial fibrillation. And for, chronic atrial fibrillation unspecified, we have I48.20. And so make sure that you keep those in place. Otherwise, you will be coding codes that are invalid. Remember what we talked about with the new codes. New codes mean that they've probably added an additional digit and that the code now is invalid. It doesn't necessarily mean that it was deleted. It just means they took it from, let's say, 4 digits maybe to now 5 or 6 to add a different aspect or a different narrative, different language, and more detail to that diagnosis. Our coding question was brought to you today by Movado Watches, one of the world's leading watchmakers. Movado, modern, ahead of its time. Movado.com. Just a side note on Movado, and I appreciate them so much. I've been working with Movado and MVMT, a branch for them that they recently purchased, for over a year now. And I have new writing utensils, so a pen and pencil set. And it's an ad campaign that was actually launched last September. It's now completed, and I'll have a new product you can order online in January. So I appreciate their collaboration and coming to me with that. Okay, so I want to end with something this week, and this is my personal insight. trying to not to keep routines constant. Do you ever feel like you're getting in a rut? I know sometimes I do. So I try something new, even if it's a new Starbucks, even though that's hard because I like my drive-through, or a new restaurant, or a new way to drive home from work, or, and don't notice the nature, notice the decor in the neighborhood, even the architecture. Or one thing, change your cupboards out at home. I switched my coffee mugs from my glasses cupboard because it was overflowing and I was afraid to open up the cupboard because my daughter lives with me and she seems like she has to have a new mug from wherever she travels to or whenever store she walks into. But now I have my mugs over my coffee pot and I'm like, why didn't I do that before? You should have your mugs over your coffee pot. But don't procrastinate. When you are sitting in your living room watching a show or reading a book, or you're just taking a moment and you look around, some of us reflect, and you see on your coffee table or you see an area that's cluttered or just looks terrible, put your show on pause, because we can do that now. Get up and just, organize it. Clean it up, throw stuff away. I did that this week and I have so much more space, and not only my kitchen cupboards, but I found also a new taco shop that delivers Pepe's Tacos in Laguna Beach. Thank you. Your El Pastor and carne asada tacos were amazing. But now I have room for Christmas to come crashing into my living room in my house without feeling like a hoarder and that my rooms are closing in on me with just stuff. So take that 15 minutes and seriously, that's all it takes sometimes. Just do something different, or what you're thinking about changing, and those small changes will make all the difference. You'll feel accomplished, renewed. Trust me, one thing I like is open spaces. I don't like a bunch of stuff in a space. And you've probably heard me over the years. See, now we're at over 2 years with our Codecast, but you've probably heard me talk about the organization. And I know some of you sent me some great photos of going to the dollar store and getting things to organize your desk. Do it in your house before you put your Christmas stuff out, and unless you're somebody who put it out at Thanksgiving. But try to do that and just try something new this week. And tell me what it is. Catch me on Twitter at TerryCoder1, or catch me on Instagram. I know some of you started following me there all at once, and I appreciate that, at Terry and CA. You can even follow me on my Twitter handle, where I am all about sports and my Pittsburgh Steelers. So that's Terry in SoCal if. So, but I'd love to hear from everybody. I even hear a lot of you on LinkedIn, which I love getting that feedback. But try something new. It's great. So that's it for me on this Terry Tuesday. Make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.